Hello, everybody, and welcome to our recording where we'll be focusing on elevated Lp(a). We'll be looking at navigating elevated Lp(a) management in the absence of treatment from a clinician as well as patient view. This webinar is an extension of the impactful work that FH Europe Foundation has already been doing in this space, and we'll focus on managing other CVD risk factors where there's an absence of an approved therapy. We will have a panel discussion how to manage living with a condition, how to manage other risk factors that will impact on our lives, and we will look on how the work of the International Task Force will impact future solutions as well. This condition is widespread. It's estimated that 1 in 5 people are affected by elevated Lp(a), although very few are diagnosed until it's too late. Again, this links to the push that FH Europe Foundation has to ensure early detection, and that this is something that is at the forefront of everybody's mind. Now, there are a lot of discussions about getting tested, and I will ask our panel to also think about focusing on the need to get tested once in your lifetime and what happens next. We have a strong belief in education, and it helps to support our community. The links to the webinar, the information that we'll share, as well as any other discussions, will be included in a link at the end of this discussion. We will also include any of the links to the International Lp(a) Task Force, and we will share the work the ambassadors have been doing to ensure that our voices are heard when it relates to the wider cardiovascular health plans for Europe and beyond. We had, for example, an ambassador, Mark Raken, and his family, who shared an emotional and impactful statement about the need to be included in the change and what that would mean for families. This recording will offer an opportunity for 2 of our patient ambassadors to share their experience as citizens living with, as well as supporting others living with elevated Lp(a), how to mitigate the risk factors. First, you need to know about them, right? And then joining us, and let us now delve deeper into how we continue to transform lives and pave the way for a healthier future. I would like to introduce you to our panel, no particular order. Theresa Donahue, a person who lives with elevated Lp(a), but is so much more than that. She joined FH Europe Foundation Ambassador Program, where she is helping us shape education program and the future advocates. She recently joined us and is already active in the Lp(a) Patient Ambassador Group, joining discussions, joining activities to raise awareness and activating advocacy in the environment. Originally from Ireland, she now resides in Switzerland. She serves as the EMEA e-commerce director of Bayer Consumer Health. She holds a master in science in international marketing practice. She's also passionate about Irish dancing, female entrepreneurship, having actively supported women entrepreneurs through the Sherry Blair Foundation for Women in Business. I'd like to introduce you now to Tobias, trained biochemist and immunologist, worked in life sciences and healthcare space at McKinsey & Company for 15 years. He also led the McKinsey's health tech service line for several years, where the focus was on healthcare innovation, health tech business building, and digital information of healthcare. He has supported public health, public sector organizations, foundations, nonprofits, health tech startups, investors, corporates in the pharma, medtech, health insurance spaces, and so much more. Geographically, Tobias has mainly worked in Europe, Africa, and Asia, so has a wealth of experience engaging in different cultures with different people. In addition to being a core member of the International Lp(a) Task Force, he is also a patient ambassador with the FH Europe Foundation, a father and a citizen. Last but not least, Dr. George Thanasolis, the Director of Preventative and Genomic Cardiology at the MUHC and Professor of Medicine at McGill University. His clinical interests are cardiovascular prevention, dyslipidemia, specifically lipoprotein A, and premature coronary artery disease. Currently, he runs the MUHC Family Heart Clinic for patients with premature CAD and their families, with the goal of optimizing their preventative care. Research interests are in the genetics of aortic valve stenosis, where he leads an international consortium investigating the role of genomic variation in this disease. He recently launched CAVS trial that will evaluate the role of targeted Lp(a) lowering in aortic stenosis. He is working on developing new approaches to optimize cardiovascular prevention in young individuals. He is also the co-chair of the 2021 Canadian Cardiovascular Society Dyslipidemia Guideline Committee. I'll now hand over, and so that they can share their journeys. I'll ask questions, answer some of the questions you may have, or anything that we've come across when navigating living with elevated Lp(a). But before we even get started, I would be interested in hearing from Tobias and MT. How did you find out about Lp(a)?
For me, it was quite recent to find out about Lp(a). I've been leading the corporate health and well-being program for McKinsey in Germany and Austria for many years, and as part of that, I increasingly got myself into mental well-being, sleep, nutrition, fitness, and the likes. And the deeper I got, the more I also explored then different conditions such as cardiovascular diseases. And as I sort of got myself deeper and deeper into that, at one point I can't remember whether I read about it or whether I listened to one of those health and well-being podcasts. Suddenly someone mentioned apolipoprotein B and lipoprotein a. And then I wrote it on my little list of stuff to get tested. And and then last year I went to my new doctor at the time, and when I walked in, I told him, I warned you, I'm a biochemist, immunologist, and here are 10 things I want you to test. But he took it pretty well, and then it came out that I've got really high lipoprotein a. And so I've known it now for a little bit more than a year. And happy to then go into more detail on both the diagnostic journey as well as then the treatment journey that I'm now on. But that's sort of the short summary how it happened.
And what about you, MT?
So for me, actually, I'm kind of generally into longevity topics, and through social media, I came across this guy called Peter Attia, who's a doctor in Canada, and actually, I think he posted something around 3 things that you need to do to make sure you have a good life. One was strength training. The second was cardiovascular checks, especially lipoprotein a, and also ApoB. And I think the third thing was sleep. So when he mentioned this, I thought, you know what, actually, I need to get this checked. I'd always had chest pain from when I was younger, but I had all the different checks that you could have checked, and cholesterol and everything was fine. And so then I went and got this tested here, specifically in a separate lab, and it came back, the results were significantly elevated. And that started me on my then now journey of figuring out what all that meant for me. But that started pretty recently, since January of this year. So, yeah.
So it sounds like both of you ended up getting more information or driven more by some of the social media aspects and somebody sharing it. So it'll be interesting to kind of delve into that a little bit more, maybe at a different time, of how we can use social media to actually activate people and get them involved. But if you're okay to share your personal journey, so if I can ask Tobias to kind of tell us about your experiences with elevated Lp(a), how it's impacted your life and family, and kind of what would you like other people to have known on this journey of yours?
Yeah, so happy to share my short journey of living with elevated lipoprotein a and the last year predominantly. Before I do that, I just want to share sort of the overall situation, since I have 2 cardiovascular risk factors. One is elevated total cholesterol and elevated LDL cholesterol. I would say that's sort of moderately elevated. And then, last year I found out that I have also elevated lipoprotein a. And I think the final thing is in terms of family history, right? My grandfather on the male line passed away with a heart attack at the age of 70 or 71, but while being sort of considered very healthy, and everyone always wondered why that was. So coming back to your question, Elsie, then my journey was the following, and I'll start with the diagnostic journey, right? So the moment I found out that I have elevated lipoprotein a, I then sort of looked up who are the doctors in my region who are specialized in lipids, right? And in Germany, there is there is a website that is run by what would literally be translated being the Lipid League, and there you can look up where you are, and you can see all of the doctors that are sort of lipid certified in your space. So then I went to one of those doctors, and then we sort of started a whole battery of additional diagnostic tests. Initially the usual ultrasound stuff, and those here and at the neck and at the groin, right, to see whether there are any sort of signs of plaques. And then I said, well, if there are no signs of plaques there, right, which of course was nice to see, what about my heart? Because I was slightly more worried about my heart and the vessels going to my heart or coming from my heart than the other vessels, right? So then we discussed a little bit, okay, are we now doing just a measurement of what people call the calcium score? Or do we do sort of a CT scan with contrast media right away to then sort of have both the calcium score as well as, a clear look at each single vessel around the heart to see whether there are any plaques and how many plaques there are, right? And that was actually very positive, and I consider myself very lucky because the calcium score was 0 and there was not a single plaque in any of the vessels around the heart. Right, so that's sort of a short view on the diagnostic journey, and of course we also did all sorts of other heart-related things like ECG and ECG while I'm sort of on a bike and stuff like that, right? But for me, the key piece of information was, the key question was, are there plaques around my heart? And if yes, how many? And do we need to do something, right? I guess maybe I'll just stop there and then we can go later into sort of the treatment journey, not wanting to talk too much in one go.
That's amazing. Thank you, Tobias. So Maria-Theresa, if you can introduce me to kind of your journey, where it started, what are some of the experiences that you've had when you first found out?
Sure. So yeah, as I mentioned, I had chest pain since I was like about 20 years of age, and I had blood panels, I had ECGs, I had all the usual stuff, and nothing came up. It was all fine. And then it was just through seeing this social media post from Peter Attia around getting this checked. So when I went into, let's say, a drop-in clinic here to ask for getting the Lp(a) checked in Switzerland, the doctor came back and said, if your cholesterol is fine, then you don't need to get it checked. At that time, my cholesterol was fine, and therefore I didn't get it checked. But 6 months later, I had another kind of bad period of chest pain, and I thought, okay, I'm going to get this done. So I went to this separate lab, you could say, and paid for it, and it was reasonable price. It was 20 francs here just to get it done, and so did that, came back with the results, and then I thought, okay, it didn't worry me because I thought I'm okay at least, and now I had this information, what can I do with it? So I went and found a cardiologist, and similar to you, Tobias, I went down the line of getting the calcium scan and the CT angiogram done here in Basel University. Everything came back fine, so phew, all good. At the same time, then I somehow got in touch with Magda from FH Europe, and she put me in contact with a lipidologist here in Basel. And so I went to him. We did updated blood panel, and at that point, my blood panel was increased cholesterol levels and increased LDL above the reference point. So that's where then the lipidologist recommended for me to go on treatment plan of lowering LDL. And so that's kind of the point that I'm at now, I suppose, where you kind of cut off there, Tobias, before you went on to your treatment plan. But essentially, he recommended to go on statins. In my mind, I was thinking I can manage this through diet and exercise. And then he kind of gave me some shocking facts to say, you need to probably rethink that, but it's up to yourself. And so then that's why I started on statins, and that's where I'm at the moment.
So both of those stories are very similar. You both kind of found out through different variants of social media rather than necessarily clinicians or health literacy that comes through. When you found out about the diagnosis, I mean, obviously it was a little bit tricky trying to navigate where you get the information from, but what impact did it have on you, your daily life and your family? If I can ask MT, if you start.
Daily life, as I mentioned, generally I'm quite active, whether I do dancing, running, or go to the gym. It was more like, what can I do maybe on a diet side of things? I still haven't really, I guess, I'm not super healthy, but I do watch what I eat. And so even more so now, you could say, in terms of that aspect. So from a daily life, that's what I'm doing now. My family, I'm not married, I don't have children, but my siblings, I have told them that I have elevated LP(a). It's genetically linked, and therefore you should go and get yourselves checked. Now, they haven't still yet. So half of my siblings are interested and half of my siblings are not so interested because of the situation. Well, what can you do with it? But for me, I think if you have the information, then you can prevent the LDL-C from going higher and going on that, essentially. So that's kind of how it's impacted my family. And actually, similar to you, Tobias, I forgot to mention, I have a family history of heart disease and sudden heart attacks and deaths and that kind of thing. So yeah, that's where I am at the moment of my daily life and family.
How about you, Tobias?
Yeah, I guess maybe there are sort of two phases. Right, so one phase was when I sort of initially started getting into the whole sort of health and well-being, or we could also call prevention topic, which is for me about 15 years ago. Right, as you said in the intro, I have a previous job that is very high intensity, right? So in that sense, when I was sort of 3-4 years into the job, I thought, well, I like the topic, I like the people. But if I now sort of work in such a high-powered job and I burn the candle from 3 or 4 sides, then this is probably not going to be a very smart idea. So I did that very early and started out with sort of stress management, mental well-being, ranging from meditation to breathing exercise and all sorts of stuff. And then from there, I went to sleep improvement, right? Improving sleep quality, improving sleep duration. From there, I then went to, like you, Marie-Theresa, I went to look, do a closer look at nutrition. Between then and today, I lost about 25 pounds of weight. And I also got more into sort of fitness and how much do I do in daily movement, right? And sort of increase my daily steps quite a bit, right? So if we sort of do a before and after, right? Sort of I increased my sleep by about 90 minutes a day. I increased my steps by maybe from 4,000 steps to about 13,000 steps each day. I lost 25 pounds of weight, and I'm probably 2 or 3 times more happy than I used to be, right? So that's sort of the journey that I've been on, right? And then I find out about lipoprotein(a), right? So for me, that was then, not a big change from my mindset perspective, right? Because my mindset, having measured all sorts of things over the last 15 years, right? I treat the health information a bit like the display that I have in my car when I drive, right? It's good to know how much petrol you have. It's good to know when you need to go to your next maintenance check. It's good to know if and how much you are over the speed limit, right? Am I freaking myself out depending on what the display of my car does? No, right? It's like, if the car says you need to get some more petrol, then you get some more petrol. So that's sort of a bit the state of mind that I'm in terms of health information, right? Which then means, Elsie, that I generally like to have more information because it doesn't freak me out anyway, and it's good to know because then I can adapt, right? And but I think in terms of what then really, if I now also switch towards the treatment side, what then really prompted me to start taking statins was the LP(a) clinical guidance website, right, where you can enter, your blood pressure and your LDL cholesterol level and your LP(a) level, right? And then for me, what I liked most was then this cumulative risk chart where it says like, okay, next year you have that risk of getting a stroke or a heart attack, and then in 5 years that, and in 10 years that, and then sort of projecting it out to the age of 80, right? And for me, that was then a real aha moment where it was like, okay, if I just let everything go as it is, right? And being in that lucky position that I now know it, but I don't have any plaques yet, right? I still have a massive cumulative risk of getting a stroke or a heart attack somewhere between now at the age of 45 and the age of 80. And then you could model out, right? Maybe we shared, or maybe you shared the link to that website along with this event, right? Then you can actually say, what if you reduce your LDL cholesterol by 50 or by 80, right? And then I modeled that out, and it was like, oh wow, I can almost cut my risk in half by taking statins, right? And that was for me that point where I was like, okay, let's try it, right? George knows this, of course, much better and should probably talk more about that, right? But in terms of what are the potential side effects or not of statins, right? But for me, it was absolutely perfect. I went on statins earlier this year. I have 0 side effects, right? Everything is completely perfect. It's a bit like, eating a vitamin pill, right? 0 side effects. And like that, I cut my LDL cholesterol now after 1 quarter from 211 to 100, right, milligram per deciliter, I think it is. And like that, I now cut my risk by half, right? And now I'm just sort of trying another quarter on a higher dose. And then after that quarter, I will then, I discussed that with my doctor, I will then do the combinations therapy, right, ezetimibe and atorvastatin, to then see how much I can push it down like that, right? But so in a sense, I'm now in that sort of titration time, right, where I just want to see what is the medication that I can use to get my LDL cholesterol down as much as possible, right? And the last thing I'll say, right, I'm hugely grateful that I found out about lipoprotein (a), because if I had just moderately elevated LDL cholesterol, I would have never started on statins at the age of 45, right? But knowing that I'm high on LDL cholesterol and high on lipoprotein (a), then it made a ton of sense to actually do that.
That's quite amazing. And actually, both you and MT are very much in there. If I know, I can do something about it. Now, we also know that that is not the story for everybody. And sometimes people really kind of, as you say, freak out about things because they're not quite sure. And with the environment, with the elevated Lp(a), it kind of leads me nicely into asking George to maybe talk to us about what is because at the moment it's mostly about managing risks, right? So what are the treatments that are available? How do we manage those risks in the absence of a direct treatment necessarily? And what are the guidelines and the future for elevated Lp(a) as far as managing it?
Yeah, thanks, Elsie. So, I mean, that's such an important question, because one of the things I see in my patients, and I'm happy to see that both Tobias and Marie-Therese don't necessarily see it this way, but one of the biggest issues I see is a lot of anxiety surrounding LPA. And, it is just one other risk factor, like many other risk factors, and it needs to be handled like information. And information is strength, and it allows us to make changes to our life to try to compensate for these risks. So, one of the number one things I tell patients is that, and there's good evidence to support this, is that individuals who have high LPA, who live a very healthy lifestyle, who basically have no other elevated risk factors, who eat a healthy diet, who exercise regularly, and who follow all of those, general recommendations, actually can reduce their risk of cardiovascular disease quite significantly. And although the LPA level itself won't change, the risk can go down dramatically by up to 70% just by very adequate control of other risk factors and living a very healthy lifestyle. And there's good evidence to support that. So the first thing I tell my patients is that this is genetic, but you're not doomed. You're not determined to have a heart attack. There are things you can do to try to help yourself and really reduce the risks of having high LPA.
So as it stands at the moment, the guidelines still have the treatments to start. So we still have statins. There's the upcoming with PCSK9 inhibitors. Some places, depending on where you live, geographically, it'll be very different, but some even offer apheresis in some cases. Can you maybe talk us a bit more about the emerging therapies as well?
Yeah, of course. So, just the first step is, the things you've mentioned already. I think right now in 2024, I think our understanding is because this is another source of atherogenic lipoproteins, the simplest solution in the meantime is to control the atherogenic lipoproteins that we can control. And as Tobias mentioned, the LDL cholesterol and the other ApoB lipoproteins should be lowered. And, that can be done very simply with, a low to moderate dose of statin in most individuals. And that's really the current recommendation. In someone who's already had a heart attack, so in secondary prevention, we often will be more aggressive in someone with high LPA, and we will consider PCSK9 inhibitors that are quite effective. It's actually one of the only medications currently that actually will lead to some reduction in LPA. So you can get about 20 to 30% reduction with a PCSK9 inhibitor. And as you mentioned, apheresis is available in some countries. It's not in many countries. It's not available, but certainly it is another option for patients who can have access to that therapy. Again, that's usually in patients who've had a previous cardiovascular event. Now, the point you bring up is what's very exciting about the LPA field right now, especially for people who've been in this area for quite some time, like myself. We now have, I think there's at least 4, if not 5, molecules in development at different stages of development that actually are targeted in reducing LPA. 2 of those molecules are quite advanced in their development and are already in the final phase randomized controlled trials. And one of those trials will read out results in a year, and we'll know whether these therapies that are directed against LPA are effective in reducing cardiovascular events. And that will really, put the last piece of the puzzle in place as to whether LPA is something that we can manage with medical therapy.
So part of that as well, we have the larger cardiovascular health plans, which I know, Tobias, you guys know a bit more about it. That's what people have been asking for, especially in Europe, it's going through at the moment. What impact will that have with individuals living with elevated Lp(a)?
Well, I think on the European side, right, we have 2 big topics on EU level, right? One is the Beating Cancer Plan, and of course there is also the cancer moonshot of the Biden administration in the US, and then there is now these discussions and development of a cardiovascular health plan in Europe. But then, as a European citizen, I just sort of think that it would be very beneficial if we in Europe, either on country level or on European level or both, would actually have cardiovascular health related plans, right? Because today, if I sort of just look at the total situation, right, we actually behave from a nutrition perspective, from a fitness perspective, from a stress perspective, right? We behave from not even talking about smoking, right? We are large parts of the population behave in a way that is not exactly conducive to cardiovascular health, and then from a government and political level, we then lament that we need to spend hundreds of billions on healthcare costs to sort out all of those issues that we created by our smoking, nutrition, and stress in the first place, right? So therefore, anyone, I would say, who looks at it like that would probably come to the conclusion that having a cardiovascular health plan is a good thing, considering that we have got so many people in Europe that go down that slippery slope of obesity, diabetes, high blood pressure, heart-related, cardiovascular-related conditions, and it's a major strain on our health systems, right? So anything that would improve that would be a good thing, right? I think the big question is how what it will entail and contain, and how much of sort of primary prevention, secondary prevention, or tertiary prevention it actually includes, and whether it will be implemented on municipal and region level, or on country level, or on EU level, and how effective the measures are, right? But if we just look at, now I sort of switch hats to my healthcare innovation work. If we just look at the levers that are at our disposal in the prevention and the health promotion space, it would make a huge impact if some of those levers that are out there would actually be applied in a rigorous, integrated way.
There we go. See, simple as that. If we now just make it work, that'll be brilliant. But yes, it will have a direct impact if everybody can work together and actually put it in as a standard for people to look at. I'll hand over to Maria-Theresa, and you've got some questions for George, I hope.
Yes, yeah. So for me, when I was getting my Lp(a) tested, I got it done, and it came back in as a milligram per deciliter. And then the second time I got it done with the lipidologist, it was in nanomole per liter. And I'm wondering, from your point of view, like, what's the best measure? And I know maybe they're not standardized. Maybe that's the question. That's the first question. Should it be standardized? And what is the better measure if somebody's going to get their Lp(a) tested, and how to interpret it?
Yeah, that's such a great question, and it's unfortunately one of our big problems in the LPA field, because we do have these various testing methods that really lead to a lot of confusion amongst patients and also physicians that are practicing that aren't really familiar with LPA testing. So the current gold standard and the method that's recommended is the molar method, so the one in nanomoles per liter, and that one's being recommended certainly in Europe and now also in Canada and other parts of the world. So that's really the recommended method. It's supposedly going to be more accurate. And with that method, the cut point of being considered elevated is 125 nanomoles per liter or greater. So it's unfortunately there's not a very simple way to convert between the units. Some people have created conversion factors. They're not particularly recommended because they do add a lot of error to the measurements. So we do hope that in the future, all labs worldwide will all move to the molar measurement and make this simple for everybody.
Right. Okay. Thanks for that. And I guess from that perspective, is there anything else that maybe, like, patients, or say if you identify that you have elevated Lp(a), is there anything else that you should get tested from a blood perspective that might also indicate things that you need to keep an eye on? Obviously, cholesterol is a standard blood panel, but is there anything else? Like, because what I had seen from Peter Attia was the ApoB measures or blood test. So yeah, if there's anything else you can recommend.
Yeah, those are both excellent suggestions. So certainly a full lipid profile should be measured with the LPA. And I speak to physicians all the time, and I tell them a lipid profile is incomplete if it doesn't have the LPA measure. And both of you would have known your LPA much earlier if we would do lipid profiles with an LPA, at least the first time around. You bring up a really important point, Maria-Theresa, with the ApoB. So we know now that ApoB is really the best marker for understanding the atherogenic risk from the different lipoproteins. So there's been a lot of focus on LDL cholesterol, and physicians still use LDL cholesterol as a marker. I think the data now is very strong to suggest that at minimum, physicians and patients should be using the non-HDL cholesterol because it's a better marker of this risk. And the best marker, and if you're going to go that extra step, is to get the ApoB, because it really does provide the most accurate measure of risk. So definitely the addition of ApoB with an LPA would be recommended. The other marker, which sort of falls in and out of favor, is the high sensitivity C-reactive protein, which I think can also be helpful. And there's some data, although perhaps not completely convincing yet, that patients who have elevations in CRP and are more inflammatory may have increased risk related to LPA. And we do know that inflammation is an important risk factor for cardiovascular disease. So that's something that could also be added in getting a proper assessment of cardiovascular risk in patients with high LPA. And of course, blood sugar and hemoglobin A1C and all the other potential cardiovascular risk factors should also be tested as part of a comprehensive cardiovascular risk assessment.
Excellent. So there's this conception or concept that people kind of adhere to, that LP(a) only needs to be tested once. Is that still the view for most?
Yeah, I mean, I think so. It's a genetic marker, and it doesn't change very much through lifetime. Probably the one area where there's still a little bit of controversy is in perimenopause, where in women there is a rise after women transition through menopause because they lose the suppressive effects of estrogen, and then therefore there can be a rise. It's still not clear how important that rise is and whether it's a clinically significant rise. But certainly, if a woman is near the threshold of being considered abnormal and they go through a menopause, they may easily find themselves in a higher level after menopause. So that would be one time where a second LPA could be recommended. Otherwise, for now, since we don't have any really targeted therapy for LPA, we don't recommend repeat measurements unless they are being placed on a PCSK9 inhibitor, or eventually, hopefully these new agents become available. And then, of course, we would have the ability to want to check to see the efficacy of those new therapies.
Excellent. Tobias, so can you kind of give us an overview of what it is that you found the most helpful? So first of all, if somebody said to you, what is elevated LP(a) and why is it important, what would you say? And then on your journey, what would it have been that would have made your life a little bit easier?
Great questions. Yeah, I think an important bit is, and George, you mentioned it to some degree, right, is considering that lipoprotein(a) is sort of an independent risk factor and an independent additional risk factor to LDL cholesterol, right? So for me, that was then that understanding and that notion that I only realized last year, that there are actually two risk factors, right? And it's helpful to know both of them, and then you can decide if and what you want to do in an informed way, right? I think that is sort of a key piece of information that I found useful, right? I think the other part is that then to sort of think about how do all of the risk factors beyond the lipids, right, like blood pressure, body weight, smoking, age, etc., right? How do all of them come together, right? So that's where I just can only recommend again this risk calculator that I found useful when it then came to the decision, do I now take statins or not, right? And I know that having worked in the healthcare and patient space, right, many let's say citizens like me who don't take any medication and consider themselves very healthy, right? There can be that subjective hurdle of saying like, oh my God, I don't want to start with medication, because then I would need to reframe my mental image of myself as from a healthy person to a patient. Right, having done that now myself, right, it doesn't change much if you take statins daily, right? I still consider myself a pretty healthy citizen, and so I think that's sort of a few considerations that I've also heard with other people, right, who were then thinking about, am I starting with statins or am I not starting with statins? And for me, it was really then seeing how much it cuts the risk, and then taking an informed decision. But I think the other part is, and maybe George, if you do not mind, that was sort of something that you just triggered with your previous response. I would be interested in from a treatment perspective, right? I understand, having now looked into this a little bit, that you can do statins as a monotherapy, and then you have the combination therapy with a statin and ezetimibe. Then you can do PCSK9, right? And I also know a few patients who then also take a low-level aspirin as well. Right, that would be something, especially the question, right? When would you do PCSK, or when would you recommend PCSK9, and when would you recommend statins? Would be a question that is sort of still somewhere in the back of my mind, and it hasn't been fully answered yet. So if you are up for that, George, that would be of interest, just from my personal perspective.
Yeah, of course. I mean, those are all fantastic questions, and I think they're really important to answer here. So, the first point you make is this idea of whether patients should be on add-on therapy with, statin and ezetimibe. I actually think that that's a great combination for patients because you can usually, we know now that whether it's high blood pressure management or cholesterol management, using lower doses of two therapies, if patients are willing to take two pills as opposed to one, actually is a more effective approach, because you often will get more lowering with less potential side effects when you do that. So that's certainly a very reasonable approach, and it may actually improve compliance for some patients who can't tolerate higher doses of statins. With regards to PCSK9, in general, those are used in secondary prevention, although they can be, theoretically, we have obviously no evidence, but theoretically, they would also be effective for a patient like this in primary prevention. Access to these medications, because they are, much more expensive, is usually one of the more limiting factors. But I do have many patients who choose to take PCSK9 inhibitors, and some of them even pay for it because of their individual risk. So it is another potential option to first of all lower the risk of lower the level of LPA, but also lower all the other lipoproteins as well. So it does work on multiple different pathways. And I think the final point you bring up, which is a really important one, I think it's something where we're going to see a lot more evidence, hopefully, in the next few months, is this question of whether patients with high LPA should be on aspirin. Now, we don't have very good data yet to suggest that aspirin is beneficial. So we don't have a large randomized trial in patients with high LPA given aspirin or placebo to know the effectiveness of that therapy. What we do have is we have two older studies that were really designed for patients on aspirin, and they've been reanalyzed looking at LPA status. And what's come out of that is that it seems that patients who have high LPA actually benefit more from being on an aspirin than the average patient. So currently, the recommendation for everybody is that aspirin is not recommended for the average patient because the risks and benefits of aspirin kind of counterbalance. So you do prevent heart attacks, but at the same time, you increase the risk of gastrointestinal bleeding. So those kind of balance out. But the data that I've just mentioned in high LPA suggests that there's much more prevention of heart attacks in patients with high LPA, and therefore that counterbalances the small increase in bleeding. So some people, especially with very high LPA, may actually benefit from aspirin. And I've started to at least bring this up as an option with some of my patients who have the highest levels of LPA, where the risks are very, very high, and who have generally low bleeding risks. So it's something that, again, the data is not very clear, but something where I think we're going to see more information as time passes by.
Thank you. I have a couple of last kind of questions, if you like. First of all, Tobias and Theresa, there's obviously research going on within this environment. Do you know about the research and the trials going on? Do you even know where to get the information from for these?
So I don't really. I think Tobias probably will have a better idea on the trials. Like, I know there are trials of probably about 5 or 6 going on, and there's one here I think in Basel. But there's a great forum that actually the LP forum website. I don't know if you guys know it, but that's a great source for like bringing everything together. And I did see that it had like one tab for the trials, and I'm pretty sure if I delved into that, I can get all the information there.
Tobias?
Yeah, well, I think one piece is if people are really, and now is sort of more the biomedical scientist from the past speaking, right? There is one piece where everyone can look up what clinical trials are going on, and that's a website called clinicaltrials.gov. And if you then enter the keyword that you're interested in, for example, lipoprotein little a, then you can see what clinical trials are ongoing and whether they are in stage 1, right, where usually safety is tested, or whether they are in phase 2, where efficacy is tested, or in phase 3, where then sort of efficacy and safety are tested again in larger number of patients. That's then something that everyone can look into and get information about what these trials are and how they are done, right? But you know, the 4 main trials that I've got, just personally having high lipoprotein A on my level, is the clinical trial by Novartis, the clinical trial by Amgen, the clinical trial by Silence Therapeutics, and the clinical trial by Eli Lilly, right? Whereas Novartis and Amgen are more advanced. I think they are both in stage 3, if I remember right, and then Silence Therapeutics and Eli Lilly are also coming up.
Excellent. I'm very happy that both the patient ambassadors in this group, at least, know where to find things. It's not always the case, and it's really difficult. So George, if you think of somebody who's kind of just arrived at your clinic, they've been asked to kind of come back to you because obviously their levels are higher. What would you suggest for them? How would you deliver the diagnosis in the first place, and where would you kind of point them to get information?
Yeah, those are very good questions. So, I mean, you know, I'm very clear with them that this is a it's a genetic risk factor for cardiovascular disease, and I give them an idea of, you know, where they situate in the sort of percentile ranks in the population, so they get a sense of how high is the LPA and how much risk is going along with that. And then, you know, in terms of where they can find information, you know, there's a few places. So there's the Family Heart Foundation in the U.S. There's obviously FH Europe, which also has a lot of information. You mentioned the LPA forum also has information. And, you know, right now there's quite a bit of information, you know, on other, you know, good quality medical websites like Medscape and other things like that on LPA as well. So I think an interested patient who at least goes to, you know, reputable websites can very, very easily get very well informed. And I'll be completely honest with you, you know, patients come to my clinic in many cases already informed because they asked their doctor to get the LPA test. They, you know, because they had a family history or some other risk factor, and then it comes back positive, and they've already done all the research, and they come into my office, you know, very, very well informed because of all the available information on the internet. So there's a lot of information out there. I just recommend people use reputable sources.
That's always a good option. There's a lot, and all the search engines will bring up some scary facts sometimes. So it's important to kind of read through them properly. So my last couple of questions is in the future. So let's think LP(a) is something that they test for. What would that look like? What would be the ideal situation of identifying people early, and where they go to from there?
Is that for me?
Yes. So if we start with George, and then I'll go around the others.
Of course. No, I mean, I think what we'd love to see in the field is that, the LPA test becomes a integral part of the lipid profile. So on the initial lipid profile, that's usually recommended depending on the country, early adulthood. People should have an LPA measured at that time. And then, that knowledge then would then trigger all the things we've talked about today, whether it's changes in lifestyle, whether it's potentially starting a patient on lipid lowering medication, whether it's optimizing, other risk factors. But just that information can be so powerful because we know that, as Tobias mentioned earlier, this is a cumulative risk. The earlier a patient knows, the earlier they are aware, and the earlier they take control of the situation with their physician, the better the outcomes will be for that patient and for society as a whole.
And lastly, to Tobias and Mary-Theresa, what would be your message if somebody is diagnosed and they are just starting on their journey? If we could start with Tobias.
Yeah, happy to. Well, I guess my main message is that first of all, it's about health and well-being overall, right? And I think even now, not talking about lipoprotein A, right? But in any case, human beings are usually happier and healthier if they get towards sustainable habits in terms of sleep, nutrition, fitness, and stress management, right? And people are happier and healthier if they do something in that space. And also, most chronic disease patients will also improve, be it diabetes or be it other diseases, if they are doing things well in terms of sleep, nutrition, fitness, and stress management, right? So in that sense, that's sort of the underlying case, right? And living in a country where everyone seems to better understand how their car works than how their body works, I think that's something that you cannot repeat often enough, right? I think the other point is that having worked professionally in the healthcare innovation space for many, many years, people usually say that health and well-being should actually be brought to school children already in an ideal state, right? But very few countries actually do it. So therefore, and now coming back to your question about lipoprotein A, therefore, if we are able to bring sort of cardiovascular health-related topics and also lipoprotein A and cholesterol and lipid-related testing topics to young people, right? And young could be school children, teenagers, or young adults. I think it will be a positive effect because it just triggers you to actually think about those things, right? Especially in a stage in life where most people or most young people often think that, they are invincible and they will be staying healthy forever, right? Which, of course, lasts for a few years and then things start to change. So in that sense, I see that positive, right? And also, currently in Germany, right, where I'm based, there is now the heart health and discussion and the heart health law being discussed, which would actually mean that Lp(a) testing will be done in teenagers so that they know these things early, right? And as George said earlier, right, it's information, and usually having better information and more information is a good thing, so that you then can react accordingly. Right, at the end of the day, we'll all die, right? So that's clear, right? But then the question is, will you make an effort to maybe have a few additional years of high quality life, or will you not make an effort? That's then also fine, right? I think that's what it comes back to, and I'm clearly in the camp of knowing a little bit more and then making a few informed decisions to have some additional healthy life years.
That's brilliant. Marie-Theresa.
Yeah, no, I would say the same pretty much as what Tobias said. Look, and as well, if you get diagnosed and you have an elevated LPA, don't worry. There are things that you can do to manage the other risk factors. And, you know, as knowledge is power, as they say, and you can only improve yourself through having this information, as Tobias and, you know, has demonstrated in his lifestyle changes. So, I mean, I think it's only beneficial for us to know about our numbers.
Fantastic. Okay, so that's the end of that. I will say thank you very much.